the need to intubate a stoma is actually relatively infrequent. It is not something that we normally do. You know, we do occasionally get a cardiac arrest with a stoma, but you know, for the most part, that's kind of more of a rarity. The thing that we do get called for a lot is respiratory distress with a stoma or with a trach tube, okay? And usually when they have respiratory distress, it's usually because of an obstruction, and that obstruction is usually mucus caused by infection. So it becomes very common in November, December, January, when people are getting a cold. You have to remember that your turbinates, your sinus cavities, all that kind of stuff act as filters, your nose hairs, right? They all act as filters to help keep contaminants out of the lungs. When these people have, they have a direct route to their lungs, and so they tend to be more prone to like respiratory infections and things like that. And when they get those infections, you get increased mucus production, and that can lead to mucus plugging the stoma, which makes it hard for them to breathe. Okay, so that's normally the case. Okay, and so usually what we get called for is we get called to actually kind of clean these things out and do that. Now, if it's a regular stoma that's not occluded, right, doesn't have something, whoops, I forgot I put that in there. If it is a regular, just a stoma, right, then you can go ahead and take your suction catheter and you can suction directly into the stoma and suction that out. And we'll talk about how to do it, because it actually is a sterile technique that you're supposed to do when you're doing that, okay? They often will have equipment at the house, if you're at their house, to be able to do this, because this is fairly common. We don't run on this a lot because most people, the caregiver, or whoever takes care of that person usually handles this. But usually we get called because there's like not somebody available, or you know, they're not in their home, or their caretaker's on vacation, or whatever. So occasionally we can get to do that. So we can actually take a suction catheter and we can suction that out, and we can do that. Okay. We could also, if you have one of these in place, right, and it gets a little bit occluded, this one's really cool. This one has a sleeve. So you could take this sleeve out and you can actually just replace this sleeve and put a new one back in. You can also take this out, and if they don't have a replacement for these, you can go to the sink, and with some really hot water, you can clean it out and try to clean it out as best you can. And then I would go ahead and suction the tube, right? And suctioning the stoma is the same way as suctioning this, right? You're just basically just gonna take your suction catheter, we'll talk about that in a second. And then once this is cleaned out, or you get a new one out of the package, then you can just go ahead and put this back in. So you kind of cleaned out the whole kind of system. The problem that we have when we suction these things sometimes is that the mucus, it's been a while, the reason why it's causing more of a plug is because it's starting to kind of harden and kind of thicken. And so sometimes you might need a little help with some sterile water or sterile saline. And this is gonna sound really crazy, but what you can also do is inject a little bit of sterile water, like up to 1 or 2 milliliters of sterile water into the stoma to actually help to kind of break it up. And at the same time, you're also going to dip your suction catheter into the sterile water to try to let it kind of drip in. But if it's really, I don't try the squirting water in there first, I try to suction first. But if I'm not getting any results from suctioning and it feels like it's kind of thicker, then I will inject a little bit of water into the stoma to actually kind of help to moisten it and kind of break it up a little bit, and then try to suction that stuff out. The proper procedure is actually, a lot of these kits, so this one has a 10 French. Okay, so this is, I'm going to show you this kit. So you open up these kits, and these kits have a bunch of little things in here. So if you look in these kits, there's a bunch of little stuff. The only thing these kits don't have, some of the bigger kits actually have a little bottle of sterile saline in them, but the little portable kits like this don't. Okay, so what you're going to find in here is you're going to have to grab some sterile saline. You could also get sterile saline out of an IV bag if you didn't have one of these on your shelf or something. You could also use sterile water. That's fine. Doesn't matter if it's water or saline. Okay, and you kind of open these kits up. Okay, So on one side, you're gonna have, remember that when you grab the outside edge, that allows you to kind of open this up to maintain kind of sterile technique, right? You go ahead and put your sterile gloves on, and we'll just talk about what's in here. So in here, you're actually gonna have, once you kind of open it up, you're gonna have your little pop-up box. Come on, open up. So now what this does is this allows you to take your sterile water, pour your sterile water in this little container like that, and put that next to your patient. Okay? Now with your sterile gloves on, you're gonna go ahead and take the catheter out. You'll go ahead and keep one hand sterile, right? So whichever hand is gonna be touching the end of the catheter, that is your sterile hand. Okay? So what I would do is with my sterile hand, I would grab this, go ahead and connect my suction catheter to this, right? Now I can grab the suction catheter in this and use this and this piece here. And I dip this into the sterile water. I put it in the trach tube, okay? You can bring this all the way down until they cough. When they cough, the cough does two things. One, it tells you you're at the carina. And number two, it tells you that you're down far enough, right? And then you're just gonna go ahead and you're gonna put your thumb over the suction, the venturi port, okay? And then you are similar, right? The difference is where they go and the tools that you have. And some people will have a stoma, and some people will have, a trach tube, okay? Trachs are usually gonna be here, right? That would be something that was actually put in, right? They put like a trach or one of the other devices that are out there on the market where you do a surgical cricothyrotomy, right? Where they cut a hole, like that video I showed you, and then they put that in, okay? So these things can be kind of interchangeable for that, all right? So this can go here. Some people also have a stoma. Stoma is usually a more permanent option. So the trach is not usually in there a long time. If you're gonna end up being where you have some damage or for whatever reason they end up putting in something that's gonna be permanent, they're gonna put in a tracheostomy tube, which is what this is here, okay? So this is gonna actually, these can be open. In other words, they can just be an open hole. And what they do essentially is they create the opening and then they fold the edges of the skin in and then they sew those together and it creates a permanent hole directly into the trachea. Okay, so they basically connect it. So anything, there should not be anything between there should not be anything in between the tissue, the hole and the interior of the tissue, right? Now they can get infected, and when they're new, sometimes they get infected, right? So those are things that you look for when they first put something like that in. But usually you can see evidence of that: fever, they might have some pain, they might have some redness, some streaking, things like that. Lab work, white blood cell count elevated, all that kind of stuff. So they would have that kind of they would have that ability to do that, okay? But essentially, they work exactly the same. So these also have the ability, so if you were gonna bag valve mask somebody with this, then you would wanna get the smallest mask that you have to hook up to your BVM, right? Because you're gonna have to create a seal here. Now this can be open or it can be closed. If it's open, then you have to close the mouth and the nose because the air that you put in here is gonna take the path of least resistance, so it's gonna come back up here and go down the lungs at the same time. A lot of these are closed. In other words, they've sealed off the airway so that there's no connection between here and here. In that case, then all you have to do is ventilate this.
Wait, I'm sorry, can you say it one more time? So this part would be open?
Sometimes the trachea is open. It depends on what happens.
Cover the mouth.
Then you have to close the mouth. So you're gonna need somebody to actually pinch the nose and close the mouth while you have somebody holding a seal with a mask and ventilating them at the same time.
Will we see that opening right here?
You'll know, no. It's all internal.
So how would we, that's, yeah, so, sorry. My question was, how would you know if they have an opening?
If they have something where they kind of cover it up, from the outside, you're not gonna know. When you go to ventilate, you're gonna hear the air coming out.
Okay.
But if they're unresponsive and you see this and you go to try to ventilate them through this and the air comes out, it's open.
Okay. Well,
But there's not gonna be any physical outward signs of whether it's open or closed.
Okay.
There's no real way to know.
Is there an indication if they try talking and they cover their like this? Is that
If they cover this to talk, then that means their vocal cords, they're still talking. In other words, they have to close this to talk.
Okay.
Then that means that it's open.
Okay.
Right? Because the air is passing past the vocal cords.
Copy.
Right? Does that make sense?
Yeah, it does.
And then some
Technically,
of
you
them,
could ventilate by plugging this hole in there.
or you could plug this hole and you could ventilate this way too. right? You could do either one, whichever one seemed to be more effective. This is usually directly above the vocal cords, correct? Your vocal cords are here. So this is actually into the trachea a little bit farther down, right? And then the ones that are closed, they'll usually have like that box, right? Where they sounds like they talk like a robot, right? That's because it's not their own vocal cords that are actually getting vibrating to create the sound. It's actually the air coming through. And how those things exactly work, I have absolutely I don't know how those things work. But the people that have that little box thing that they, I'm Stephen Hawking's, right? I love Robin Williams. Call it Stephen Hawking's phone. This is Stephen Hawking's. Oh, I'd like to leave a message. This is Stephen Hawking's. All right. Sometimes they have these tubes in here. Okay. So these tubes are really simple, right? All you have to really do is they just go in and they just kind of go in at an angle. These tubes have what's called an obturator. Okay, so the obturator is also a stylet for these tubes. You don't actually need it to put these in, but it does help. In this case, this one's pretty flat on the bottom, so this is kind of round, so this just kind of helps to facilitate the shape. Okay, and then all these really do is they just basically go in. You want to lube these up, okay, little lubricant, and then this just goes in. You seat it, you don't have to worry about how far it's supposed to go. That's it. You just tie a little tape here. These you can do a string to tie onto the end of these things. Okay, and then you inflate the cuff. Sometimes the cuffs will tell you how much air is supposed to be inflated. Sometimes they don't. General rule of thumb is just inflate the cuff until pilot balloon is full, and that's all you need. And then you pull out the obturator, and now you basically hook up your BVM to that.
And this is something that they would have with them?
This would be something that they have,
Okay.
right? All right, now you get to a call and you have a patient with a stoma, okay? And you can't really do this for the trach. If they have a per trach in, this will already be in there. In other words, they're not gonna leave a hole where in the cricoid-thyroid membrane, right? If they've been criked, right? If they have a crike in, then this will already be in place. And then the only thing you really have to worry about that is gonna be what we're gonna talk about next, which is suctioning, okay? But let's just say you have a patient that you don't have any of these. They're at grandma's house and there's nobody around. They don't have any of their equipment and they don't have any of these stomal tubes to use, and you've got a cardiac arrest. So you don't have to close the mouth even if it's open, because this is not gonna matter. Is you're just gonna take a regular ET tube, and you can see this one, they've actually already cut it. So what you're gonna do is you're gonna take this ET tube, you're gonna take off the end, you're gonna cut the ET tube to the lowest you can cut it is to here. Did you see the other end of the tube? Do you see it there somewhere? That's not it there.
This?
No, that's the other end. I want the other end. the end that should be in here. I don't want to. I can cut this up too. So what I would do is I would just take this ET tube. And I would just cut this off right here. Make sure you do it above the pilot balloon, because you still need the pilot balloon. Then you put a little lubricant on here, and then you just take the tube and you just kind of insert it. I don't have a syringe. You see the syringe there?
So this is if they don't have any.
If they don't have a trach tube, or they don't have the ability to use one of these, then you're just going to intubate the stoma. This is called stomal intubation. And it's the easiest intubation you've ever done. You put this in, right? You only need to go in about that far, right? You just want to get the cuff past inside of the trachea, and that's it. You inflate your cuff, you hook up your BVM, and then just the tube tamer won't work on this. I'm going to look around later on to see if I can find some twill tape, but I would use twill tape for this. You could also use regular tape. You could use transport tape. You could use duct tape. And basically just a couple wraps go around the neck, come over here, a couple wraps on top. They do make tube tamers. Your agency may have them, not the big bite blocky ones, but they actually look like a foam pad that kind of comes around behind the neck, and then they have two pieces of like tie down things that you can actually just peel off, and then you wrap those around the tube. But now you can just hold this right here, but I always cut them, and then you just pop this off, and then this would just go on wherever you cut it,
Oh, okay.
right? You're just making this shorter because this is a little unwieldy.
And you don't care about depth at all for this one.
The depth is as soon as the cuff is past the hole,
Okay.
maybe go another like centimeter past that and inflate your cuff and you're done. That's Stomal innovation. Super easy. Now